Our next lesson is going to cover findings for the abdominal aorta. Abdominal aortic aneurysms have an annual incidence of 0.5% for American adults. The prevalence increases with age and is rising to be 2.5 to 6.5 aneurysms for every 1,000 person years for the average U.S. citizen. Risk factors include advanced age, males, white race, a history of smoking, and a positive family history of aortic aneurysms. Surprisingly, although we know that there is sort of vasculogenic disease that can occur with type 2 diabetes, diabetes itself seems to be protective, or at least seems to be associated with a lower risk of AAA, despite its effects downstream in smaller vessels. So that's sort of an interesting thing to think about. Abdominal aortic aneurysms are usually asymptomatic. However, when they are symptom-producing, pain is the most common complaint. The classic exam finding of a pulsatile abdominal mass that's taught in textbooks and in medical school is usually only present in about 30% of cases. Most commonly, these are found as incidentalomas when a patient is in the hospital or ER or undergoing evaluation for something else. And they take on different appearances such as fusiform and saccular, all of which can still be dangerous for our patients. The USPSTF recommends screening all men aged 65 to 75 years of age who have ever smoked with a one-time ultrasonography. This is a grade B recommendation from them. And then there's grade C recommendation for men who have never smoked based on individual patient factors such as their family history or other medical comorbidities. It is not recommended that we screen women who have never smoked, but those who have, there's not great evidence one way or another. That's an I recommendation and should probably be discussed as a risk-benefits analysis with your patient. However, I would advocate thinking about doing these screenings, especially because the more screenings that you do in patients in your clinic, the more likely you are to recognize abnormal when you see it. Let's go through the abdominal aortic aneurysm screening technique. The guidelines for performing a ultrasonographic screening test for AAA are outlined in the AIUM practice parameters seen here, and this is where I've devised our recommendations for our curriculum for almost every test that we do. Once again, the best probe of choice for the AAA exam is going to be the curvilinear probe because of its depth penetration and good resolution for deeper structures. However, if you're in a situation where you only have a phased array probe, that would be acceptable as well. Generally, we're going to ask that our patients be supine for this exam, and there's no benefit for having them in Trendelenburg or reverse Trendelenburg. This is also another scan that is going to be better having the patient be fasting because the bowel gas that will overlie the aorta can be disruptive for adequately visualizing this structure. So we need to go over some aortic anatomy because this is really important that you're able to identify these things to be able to take measurements at the correct places. So while there is some physiologic variability in the aortic anatomy and the branches of that anatomy that come off of the aorta, in general, we should remember that there are three unpaired vessels that come off of the aorta, generally at or close to the midline in the anterior plane. So the first of these is the celiac trunk. We also have our superior mesenteric artery. And then our last unpaired vessel is down below at the inferior mesenteric artery. Between the superior mesenteric artery and the inferior mesenteric artery, we have the takeoffs laterally for the left and right renal arteries and the gonadal arteries. Then we get to that IMA, and then finally move down to the iliac bifurcation. This is important to note because we divide the aorta into different sections that need to be individually visualized. So the proximal field consists of the takeoff of the celiac trunk and superior mesenteric arteries above the takeoffs of the renal arteries. The midsection is overlying the renal arteries above the inferior mesenteric artery if possible. And then lastly, the distal aorta consists of the tapering cone right up through the iliac bifurcation. So according to the AIUM, a complete AAA screen would include a long axis view of the proximal, mid, and distal aorta, a transverse view of these same three sections, and measurements of any aneurysm that is seen, or the largest portion of both of these measurements in the longitudinal and transverse planes. So how deep and how wide are each of these sections, even if an aneurysm is not seen. Taking a measurement of the aorta consists of being able to recognize it, right? So once again, to review, we have our curvilinear probe here, footprint. We've got some overlying soft tissue and mesentery, and then we see this echogenic, brightly reflective surface of our vertebral bodies. And just above that vertebral body, we have these anechoic structures representing the aorta, typically on the patient's left side, and the IVC typically on the patient's right side. However, this can be variable, and if you happen to have your probe on backwards or something like that, this left-right differentiation can get disrupted, and so you cannot use location or pulsatility alone to identify these structures. So here is my dog, Doppler, the sweetest boy ever. His name is Doppler for my love of ultrasound, as you might expect, but he's here to remind us that we need to use Doppler color flow to determine which vessel is which. And let's go over how to do that. But let's take a minute and just look at him because he's so cute. So when we have our probe on the patient, remember that color flow is directed in a way that shows up on the screen as colors based on whether flow is occurring away from the probe or towards the probe. So if we have our probe down on the patient's abdomen like this, tilted slightly towards the patient's head, where the indicator is pointed towards the patient's right side, and the back of the probe is sort of tilted away from the patient's head, what would happen if we're looking at the abdominal aorta here? What color would you expect to see in the aorta? Well, we know that blood leaves the heart through the aorta and then flows down, so it should be coming towards the probe. So in this position, we would expect the aorta with color flow to show up as red. And conversely, the IVC with flow moving back up towards the heart would be blue. And sure enough, that's exactly what we would see. However, if we tilt the probe the opposite direction and now look towards the patient's feet, the color will switch. And so now our aorta is going to show up as blue and the IVC would show up as red. So this is purely an artifact, or it's arbitrary based on which direction the probe is pointed, and is not a reliable indicator of artery versus vein unless you can visualize which direction that flow would be coming, whether it's towards or away from the probe. And the mnemonic device to remember this is BART, blue away, red towards. There's probably some other ones out there, but this is the one that I can remember, and so it's the one that I'll be teaching you, or that you'll hear me reference when we're in POCUS clinic together. But please, please, please remember, you cannot rely on position or compressibility or pulsatility alone to identify the aorta. You have to use Doppler color flow and document an image proving how smart you are utilizing this to make sure that you're measuring the right structure. I think that I've beat that horse quite dead, so let's go ahead and move on into looking at each of the zones of the aorta and how we take our measurements. Let's start with the proximal abdominal aorta. So once again, our proximal abdominal aorta consists of the region of the aorta at which we have the takeoff of the celiac trunk and the superior mesenteric artery. So our landmarks are going to be the aorta and both the long and short axis. And then there's something called the Siegel sign and the rising sun of the SMA. So this is the area we're focusing on, and let's focus in on this image up in the upper left-hand corner. In the longitudinal view, we will see the celiac trunk take off and almost immediately start branching into the hepatic and splenic vessels. We see our splenic vein returning from the spleen, and then we also see the superior mesenteric artery arising and starting to course inferiorly towards the mesentery. And so in the longitudinal view, this is the view that you're looking for. And you can actually see that there's a lot of sort of connective tissue at this portion of the aorta. There's vascular structures and some fat that's protecting these larger vessels, and that actually helps us really clearly identify these takeoffs most of the time. If you have your probe and you're sliding down, translating, looking for these takeoffs, you can usually pretty readily identify them. Let's take a look at what they look like in the short axis. So in the short axis view, there's something that's called the Siegel sign. And what we mean by that is that we can see this celiac trunk taking off of the aorta right here and then immediately branching into the common hepatic and the splenic arteries. And this looks sort of like, the profile of a bird, if you're drawing a bird flying in a Bob Ross painting or something like that. And so that is what the celiac trunk looks like, and we call that the Siegel sign. And here's a picture of a seagull to remember that. The other thing that we can see right at the very end of this clip is the circular structure that's coming off of the aorta just past the celiac trunk, and that's actually our SMA. I've heard this referred to as the rising sun sign. So as you translate your probe or fan your probe superior and inferiorly, it almost looks like a sun rising over, kind of surrounded by this brightly echogenic ring. And so that can help you identify the celiac trunk and the superior mesenteric artery, or the SMA, which is the first area where you want to make a measurement of the aorta. Let's move on to the middle abdominal aorta. Unfortunately, in this section, there are really no reliable landmarks. Every now and then you may be able to see the takeoffs of the renal or gonadal arteries, but they're not always visualized. And so really what you're going to be doing when you're taking a measurement for this section is looking at the proximal and then the distal measurements or areas, and then going in between them and taking a measurement in this mid zone. So if you've translated down inferiorly from the proximal and then you reach the iliac bifurcation without seeing any of these other landmarks, go back up a little bit before you get to the superior mesenteric artery and take a measurement around there, ideally below the infrarenal, or below the renal arteries in the infrarenal zone, and that will be sufficient. Here's a zoomed in picture of what these renal artery takeoffs, when they are visualized, look like. So it sort of looks like the planet Saturn. So you've got the central structure with a ring or a line as these arteries take off laterally in course to each of those different kidneys. Moving on to the distal abdominal aorta. So here we are in this section where the aorta tapers until finally dividing into the right and left common iliac arteries. And we use, up here you can see on Doppler flow, this one single image is being slowly broken up into two separate flows that represent the bifurcation. And so our landmarks, you may or may not see a takeoff for the inferior mesenteric artery, which would be coming off of the midline. But oftentimes I don't visualize that just because it can be so superior to the iliac bifurcation. But every now and then you may see it in the same view. You should also see that tapering aorta, and then a video is preferred here to demonstrate that you've captured the most distal portion of the aorta as it bifurcates into the iliacs. Let's go over what a AAA screening measurement looks like. So remember that POCUS is a clinical tool that's designed to answer a focused clinical question and not a full imaging study. And in this case, our clinical question would be, what findings on point-of-care ultrasound would be most suggestive of an abdominal aortic aneurysm? And another way to simplify this question is basically asking, how should we measure the aorta, and what measurement would be abnormal? The easy answer is from the outside wall to the outside wall. But if you don't know how to read an inch tape or a ruler, let's go over it just in case. So in the longitudinal view, this is what you're going to be looking for, and this is our proximal aortic zone. And here, because this is a screening test, remember we want to try to identify the widest diameter possible and take the widest measurement of that. And so that's why we're going to be measuring from the outside to the outside of these wall vessels or vessel walls. And so here you can see sort of there's this brightly echogenic line, our anechoic aorta, and then the posterior wall. And I've put these tips of these arrows right at the very edges of the last kind of structure that I could consider to be the wall of the aorta. And taking that measurement is where we need to get our first value to determine whether or not we have an abdominal aortic aneurysm. So once again, we need to take measurements from the upper, middle, and lower, or proximal, middle, and distal aortas. And then we have to compare for each of those whether or not the aorta is widening. So although the aorta can be a slightly different size, I'll go over some parameters for what's normal and abnormal here in a second. But one thing that is important to remember is that if you see significant widening of any degree, as you move distally towards the patient's feet, towards that iliac bifurcation, that can be abnormal and can be a sign of a AAA. And so even if the abject measurement of the aorta is normal or within a normal value, if you're sliding your probe, translating it down, and seeing widening, that's someone that you might need to refer to a formal study if you're not able to make a diagnosis yourself of an aneurysm, because that can be those subtle ones that sometimes go missed by point of care exams. So here's examples in the transverse view of each of these three sections of the aorta being measured from outside wall to outside wall, and the cursors in place for proper measurement of the AAA. So what aortic diameter is suggestive of an abdominal aortic aneurysm? Well, the long answer is that it depends on the patient's age and body surface area and all of these other factors. And there's a nomogram here that you can use this really complicated calculation to get their height and weight, to get their body surface area, and then compare on a normative equation what their z-score would be. But no one has time for that. And so for a point of care study, we'll simplify this just a little bit. So what's a normal aortic size? Well, a AAA has 3 letters. We need to take 3 pictures of it in the proximal, the mid, and the distal fields. And so naturally 3 centimeters is a good arbitrary cutoff for the upper limit of normal. And this is pretty accurate. There are going to be some people that will screen positive falsely, and there will be some people that are missed that do have a true aneurysm. But for screening purposes, this is an adequate cutoff. So 3 centimeters is the upper limit of normal. And this just sort of codifies that a little bit more. So remember that older men who have really high atherosclerotic cardiovascular disease risk factors, or have known vascular damage from smoking or from other comorbidities, will generally have larger aortas than, for example, a young healthy woman would. But regardless, as I mentioned earlier, if your scanning in the aorta is not tapering, that is abnormal. And then in adults, the accepted quote-unquote upper limit of normal for the area of the aorta below the kidneys is 3 centimeters. Officially, if you're taking a board exam, the 2 positive characteristics would be a diameter greater than 3 centimeters or an infrarenal distal to proximal ratio of 1.25, which is just putting a number on that concept I talked about, that you shouldn't see the distal aorta widen as you're moving distally. It should kind of taper and be a nice cone shape until you get down to the iliac bifurcation. So if you're getting a widening greater than 25% of any more proximal area, that is abnormal and you need to refer them. So let's go over some examples of what positive abdominal aortic aneurysm screenings might look like. So on first glance, this may appear to be a normal aorta. We see an anechoic structure here with a hyperechoic ring down here, and it looks like it's about 3 centimeters, maybe a little bit less. But as you take a closer look, you can see that the walls of this aorta actually extend all the way up here. This brightly echogenic ring is the wall, or the vessel wall. And this portion here that is more echogenic, so it's not completely anechoic, but it's still hypoechoic to other structures nearby, that is actually clot that has formed inside the aneurysmal the pocket of this abdominal aorta. And so this is a positive screen, because if we measured from here all the way down to here, we see that we're 1, 2, 3, 4, 5, 6 centimeters of diameter. And so this would be a positive AAA screen. Here are some other examples of the same concept. So here we have these letters up on the top in the transverse view correlate to the letters on the bottom in the longitudinal. Here's an example of a finding that's called a smoking aorta. And what we see is this sort of swirling whirlpool-like structure inside the lumen of the aorta, and that represents turbulent blood flow, maybe with even some clotting or some plaque formation inside of that aneurysm. This is another example. If you took a measurement from the top to the bottom here, there's at least 8 centimeters, if not 9, 10, 11 centimeters of this aneurysm. So this image shows a longitudinal view of the aorta. So there's the iliac bifurcation right down here at the right side of the screen. And so the aorta normally should be sort of tapering as it comes this direction towards that iliac bifurcation. But instead, what we're noticing is that there's this large aneurysmal component. You've got clotting and kind of some debris here between the two layers of a wall, probably with a dissection. And this is a longitudinal view. Certainly would be more than 3 centimeters of depth if we were taking a measurement here, and representing, once again, an abdominal aortic aneurysm. So while this doesn't seem like a pretty difficult exam, there are a few pitfalls that can make measuring the abdominal aorta pretty challenging. So first is that the IVC stands for imposter very close in this setting. It's right next to the aorta, and if you are not directly on axis, or if you twist up your probe or just happen to slide off a little bit, you may take measurements of the IVC. They can look very, very similar. You often will find a pulsatility even in the IVC down in the abdomen, and so you've gotta use that colored Doppler flow to make sure that you're not measuring the IVC. Remember that axis will also matter, so you need to be in a perfectly longitudinal or a perfectly transverse orientation, because oblique measurements are inaccurate and they can result in missing or overdiagnosing a problem if you're not taking a true cross-section measurement. Dissections can happen at any diameter, and so remember, the aortic dissections may be present even if the aorta is measuring a normal size. And so you have to kind of separately have in the back of your mind, if someone's having abdominal pain, or if you're just happening to see something that looks a little bit odd, that this could be an aortic dissection. And we'll look at that here in a few slides as well. And then remember that 1.25 distal to proximal ratio, especially in smaller patients and in female patients, that could be representative or diagnostic of a AAA, even if the absolute measurement of the diameter is quote unquote normal. So if you do happen to identify a AAA, or you have one that's identified externally, what should you do to follow these patients? Well, if it's a small one, only measuring less than 4 centimeters, these patients generally are recommended to get a follow-up ultrasound every 3 years, or of course sooner if they're having worsening symptoms. For slightly larger ones that are above 4 centimeters, those patients need to be followed annually with repeat ultrasounds. And then for once we get to the cutoff of 5 centimeters, that's when you really have to refer for surgical treatment. Although I would advocate, anytime you see a AAA, go ahead and get them established with surgery, and they can make recommendations for follow-up as well. However, if you're not managing it surgically, if the patient's declining or not a good surgical candidate, then you could consider doing ultrasounds every 6 months. After they've had a AAA repair, including like an endovascular repair, there's different recommendations. And honestly, I would recommend that we follow those guidelines from the surgeons to figure out if you need to continue to surveil them. Most of the time, they will ask for you to get some repeat imaging at some point. But that's going to be very dependent on the type of repair that's done and the patient risk factors and those kinds of things. Let's move on and talk briefly about aortic dissection. So aortic dissections occur with or without the presence of an aneurysm. And basically what happens is that the wall separates and you get extravasation of blood into the between the two layers of the wall. And what this often looks like on ultrasound, and I've got examples here in the longitudinal view on the left and a transverse view on the right, is this kind of trampoline looking membrane that you see inside the lumen of the aorta with anechoic collections of blood on either side. And so one of these represents the true lumen and then the other represents the dissection. It's not always easy to tell which one is the true lumen on ultrasound. You would think it's the one that's going to be bigger, but that's not always the case. But obviously an aortic dissection is a life-threatening condition that needs to be referred for repair or stabilization immediately, usually in the inpatient setting. So in this lesson, we reviewed aortic aneurysm epidemiology and talked about the USPSTF guidelines for screening for this condition. We reviewed normal aortic anatomy and talked about the exam technique. We talked about using measurements in both the longitudinal and the transverse planes of the proximal, mid, and distal aortas, and how you need to take measurements in both of those planes for a complete exam per the AIUM guidelines. We talked about a positive screen and what those cutoffs are, 3 centimeters for a normal aorta, or any significant widening as you move proximally to distally that represents maybe a sub 3 centimeter aneurysm that could still be positive. And then we also briefly looked at what aortic dissection might look like on an ultrasound and saw that trampoline sort of bouncing membrane that needs to be evaluated quite urgently to keep patients from having high mortality or morbidity. And so that sums up our review of the abdominal aorta on point of care ultrasound. And I will see you in the next lesson where we're going to talk about renal and bladder ultrasound.